Again, a good day, my dear postgraduate students. Welcome to the third class of Glide the Slide. I hope you have done enough references for this particular case. Incidental finding on CT scan, a lesion in the retroperitoneum, measuring 4.5 centimeters in diameter. Almost when a history is given, every word will be important. 1. Incidental. 2. Retroperitoneum. 3. 4.5 centimeters. Having said that, what am I seeing on the screen? I am finding one thing that is striking me is large vacuolated cells. Something like what we draw in a lipoma, maybe of varying sizes. And they are being incompletely separated by fibrous tissue, and some of them are spindle enough to give me an idea of a smooth muscle or a myofibroblast. The third one will be thick-walled blood vessels, which are somewhat having an irregular lumen and a varying thickness of the wall. So the diagnosis can be, this can be a lipoma. Usually, when both are seen, we used to give a diagnosis of fibrolipoma. But then this third crook is also over here. So the diagnosis can be angiomyolipoma. This is in fact a better slide. I am finding groups of these mature adipocytes which are getting entrapped in a dense connective tissue stroma, which is clearly revealing spindle-shaped cells. So the adipocytes and the myocytes are quite clear. As I had been mentioning earlier, there are thickened blood vessels. There can be some amount of hyalinization that is present, but what is more important is, as I told you, look at the irregular thickening of the walls, which is supposed to be one of the striking features. So it is dysmorphic, disorganized. There are hyalinized blood vessels. There are myoid differentiated spindle cells. There is a variant called as epithelioid. We shall not be going into it. Mature adipocytes. Sometimes there can be cystic spaces with hobnailing of the line. So a very common slide for the postgraduate exam. It is one of the most prevalent benign tumor of the kidney. Again, a controversy as to whether it is a hamartoma or a tumor, a benign or a malignant. The books say that a diameter of less than 5 centimeters shall be considered as benign and be left alone unless it is causing a pressure effect. But then, when there is going to be a rapid increase in the size, it can be suspected to be going in for a malignant change or to cause pressure effects. 80% of the cases are sporadic, 20% familiar. The patient can present with flank pain. In fact, any of the renal masses, flank pain or mass is one of the classical histories. Hematuria, typical of renal cell carcinoma also. And this also having a varied presentation can be mistaken for a renal cell carcinoma, but in this case, there is no hemorrhage, no necrosis. Retroperitoneal hemorrhage can be present because of the tumor. Another lesion that is associated with it is the tuberous sclerosis. The angiomyolipoma can be found in the brain, the heart, lungs, kidneys. 1 per 10,000 population. Not very uncommon. Discovered by Gravitz in 1900. But be careful, it is not Gravitz tumor. Gravitz tumor is actually the proper name for renal cell carcinoma, otherwise called as hypernephroma, because it was thought to be originating from the adrenals. It consists of, that is, the angiomyolipoma consists of adipocytes, smooth muscles, perivascular epithelioid differentiation. There are three components. So it can be monophasic when one is dominant, biphasic when two are present, and triphasic when all the three elements are seen. Generally, it is unilateral, but it can be bilateral in tuberous sclerosis. Usually solid, but can be solid and cystic. 6 centimeters is the maximum average diameter that is given. Greater, there is a chance for malignant transformation. Tortuous blood vessels can be indicative of an aneurysm. Perirenal is one of the most common signs. Sometimes it can occur within the renal parenchyma, causing a confusion as to whether it is an RCC or angiomyolite. Circumscribed, with or without lobulation. Lobulation means you find dome-like elevations externally, but not capsulated. Hemorrhage can be present, no cystic changes, no necrosis. This is the catch. Even recently we had a confrontation, but no necrosis rules out a renal cell carcinoma. The appearance depends on the components. Yellowish color, more of adipocytes. Look at this. I am able to see the parenchyma over here, and it can extend into the perirenal fat via the lymphatics. There might be tumor thrombi which lead to the inferior vena cava. There is a defect in TCS1 and TCS2 genes. Unchecked activation of mTOR pathway. These two are supposed to be indicative of the pathogenesis. Coming back to the picture, I am finding that it is very irregular, but still circumscribed, no definite capsule. It has got broad ways of intrusion. There is no infiltration. This is a much better picture thanks to this reference over here. Thick walled blood vessels, eccentric thickening of the wall. Then myofibroblasts or myocytes. Therefore, there will be the entrapped adipocytes. A superb picture of an angiomyolipoma, a definite exam slide for you people. Hats off to these people who are all dedicated in their research. And this incidentally, before I plunge, I hope you people are able to identify the organ over here. It has got some kind of a pale and then a dark area, but still they say there is no full-blown cirrhosis. It is a liver. And this is also an uncircumscribed lesion or a circumscribed lesion. There are some areas of hemorrhage. If this alone is given, I would think of a hemangioma. But then there are these pale yellowish areas which are making inroads into it, and there are some gray areas also. So angiomyolipoma is the diagnosis. So all this has been covered. HMB25 can be done to rule out a sarcoma of the liver. So basic medical key is the source of this particular picture, thanks to them. Now, what are we to recollect in this particular region? Ill-defined, no capsule, it can be abutting the kidney. Adrenal, there can be fat, be careful about it. Luteoma, again, can be yellowish in color, that can be a differential diagnosis. No necrosis, no variegation. It can be monophasic, biphasic, or triphasic. And this is one. There is a tumor over here, the normal renal parenchyma. Obviously, it is different. If it is given for the exam, don't make a diagnosis of renal cell carcinoma. Let's glide to the next slide. This is again an incidental finding in the left arm of a 19-year-old boy. Courtesy web pathology for this particular picture. This shall be discussed in the next slide, and you come well prepared with your answers.